Welcome to our program tonight, Hiding in Plain Sight, a focus on diagnosing homozygous familial hypercholesterolemia and addressing its unmet needs, which are quite significant, as we'll soon see. My name is Seth Baum. I'm a preventive cardiologist and clinical lipidologist, past president of the American Society for Preventive Cardiology, and a president and chief medical officer of Excel Medical Clinical Trials, which is a Flourish research site. And I'm happy to be here tonight, joined by my colleague, Kathleen Byrne, nurse practitioner at Johns Hopkins University in both adult and pediatric cardiology. So here are my disclosures. Here are Kathleen's. You can see I have more. And I'm proud of everyone. So this is what we're going to cover tonight. Now, remember, we can get credit for this. So we have learning objectives. We'll have pre-test questions. We'll have post-test questions. And I encourage everybody to go online and get your credit for this hour that we're going to spend. So we'll describe the prevalence of HoFH, or homozygous familial hypercholesterolemia, and also its underdiagnosis. We'll discuss how to apply cascade screening in clinical practice as a cost-effective strategy, which helps us diagnose FH, or familial hypercholesterolemia, in close relatives of patients already diagnosed with FH or with homozygous FH. We'll outline how to integrate currently available therapeutics with novel mechanisms of action into the treatment regimen of patients with HoFH. And we'll explain how to increase accessibility of newer LDL-lowering therapies to patients with HoFH. And as I think everybody knows, that can be a real challenge. So we look forward to a lively discussion about that. So we'll start with the pre-test polling questions. And the first one is, approximately what percentage of patients with FH are underdiagnosed? What percent are underdiagnosed? I'm leading the witness. What percent underdiagnosed, have not yet been diagnosed? Okay. Well, I think we may have a few more people. Give it a moment. Okay, now we can move on. So a 28-year-old woman was recently diagnosed with homozygous FH. She has 2 children and an older brother. Based on diagnostic screening criteria, who else in her family would warrant screening? Her children only, her children and her brother, all of her first-degree relatives, and no one else should be screened. This one's impressive, but I'm not telling you the answer, but it's very impressive. All right, we can move on to the next. A 27-year-old patient with a positive genetic test and confirmed diagnosis of HoFH is taking ezetimibe and rosuvastatin 5 milligrams every other day due to low tolerance of statin. Which of the following therapeutics would you recommend next? Bempedoic acid, evinacumab, inclisiran, or just continue Rasuva at the 5 milligram every other day dosing? Okay, let's move on. You've prescribed a novel lipid-lowering therapeutic for a 27-year-old woman with recently diagnosed HoFH. Which tool will you provide to ensure adherence to therapy? A PCSK9 inhibitor, prior auth form, letter to the family template, repeal request, A and C, A and B. All right. Great job, everyone. So now we're going to move along with Ms. Byrne giving us an overview of FH.
Okay, great. Thank you. So familial hypercholesterolemia is a common life-threatening genetic condition that's associated with very elevated LDL cholesterol levels. In fact, it's the most common genetic disorder that is associated with lipid metabolism. So LDL elevation is present since birth, and it occurs in all races and ethnicities. Okay, give me just a second. My computer just went out on me. Okay, great. Now we can move on. Okay. So it even occurs in certain ethnicities more than others. And that's due to what we call the founder's effect. So you may see it in French Canadians, you may see it more in Ashkenazi Jews, in Afrikaners in South Africa, and in Christian Lebanese. And when FH is unrecognized and therefore untreated, it's associated with premature cardiovascular disease and death. And it's very important to note that only about 10% of all individuals in the United States have been diagnosed. Only 10%. So there's a lot of people that are out there waiting to be diagnosed. Some individuals with FH will have physical signs with cholesterol deposits noted on their eyelids, so xanthelasmas, in the tendons, but others will have no physical findings at all. And I know when folks are diagnosed, oftentimes they'll say, geez, how can I have very high lipid levels? I'm not overweight and I eat well. Therefore, surely my cholesterol can't be elevated. And they have some denial going on. Well, anyway, moving on. FH is identified as either being heterozygous or homozygous. Heterozygous FH occurs when one abnormal genetic mutation is passed down from one parent to a child. And when an individual inherits an abnormal mutation from both parents, they are said to be homozygous. So FH primarily follows an autosomal dominant pattern of inheritance, with the three most common genetic mutations being in the LDL receptor, ApoB, and PCSK9. Now, we also have, less commonly, we see a defect in the LDL RAP1 gene, which is commonly known as ARH, or autosomal recessive hypercholesterolemia. And that is just as it says, it's inherited in an autosomal recessive manner. This particular phenotype has a milder presentation than the other three. Currently, there are more than 2,000 variants that have been identified, and I would venture to say that every few weeks we find more pathogenic variants. Sometimes when genetic testing is done, we get genetic results. They come back as unknown significance, only later to discover that it's a pathogenic variant. So now moving on to, again, these two pathogenic variants, HE, or heterozygous FH, and HoFH, or homozygous. Heterozygous FH is the most common form, and that occurs in about 1 out of every 200 to 250 individuals. Remember, these folks have received one genetic mutation from a parent. And we begin to think of someone having heterozygous FH when the LDL cholesterol is greater than 190 milligrams per deciliter in adults and greater than 160 milligrams in children. But please keep in mind, this is not an absolute. You can have lesser numbers and still be diagnosed with FH. We may begin to see the onset of coronary heart disease or premature heart disease in 30 to 60-year-old folks who are untreated. Most individuals with heterozygous FH respond to drug therapies but it's noteworthy to say that it usually involves, or certainly involves, more than one lipid-lowering agent. Now, on the flip side, homozygous FH is more rare and more severe. It occurs in about 1 out of every 170,000 to 300,000 individuals. It's a lot more common, though, than we used to think about. When I first started in this field over 20 years ago, I remember being taught that it occurred in 1 out of every 1 million individuals. And boy, have we learned a lot more and see it a lot more because we've started to really look for it. The patient is identified as having 2 genetic mutations passed down, 1 from each parent. And these LDL cholesterol levels are markedly elevated, being greater than 400 to 500 milligrams per deciliter. The onset of coronary disease can most certainly be during childhood, if not treated, with the first MI being seen in late school-aged or early adolescence. And physical findings are certainly present and will be discussed by Dr. Baum in a few moments. The management of homozygous FH is certainly more difficult than managing a heterozygote. It requires multiple medications and or treatments, including LDL or lipoprotein apheresis. And despite the approval of many new drugs in the past decade, it really remains a challenge to bring individuals closer to their goal. Now, here's a look at a family tree of individuals who have heterozygous and homozygous familial hypercholesterolemia. First, let's just keep in mind that children of an individual with FH have a 50% chance of inheriting this disease. So if you look on the left side of your screen with the pedigree of the heterozygote, you can see that the grandmother had familial hypercholesterolemia, heterozygous. Grandfather didn't have anything, and the father ended up with heterozygous FH. On the flip side, look over on the right side, homozygous FH, and parents who each have heterozygous FH, they have a 25% risk with each pregnancy of having a child with homozygous FH. There's a 50% risk of having a child with heterozygous FH, and a 25% chance that the child will inherit a normal gene from each parent. And now I'm going to turn it back over to Dr. Baum, and he's going to discuss screening and diagnosis for familial hypercholesterolemia.
All right, so a recurrent theme that we're all going to be talking about tonight is, are we missing the diagnosis? And that is key. And this applies, our focus tonight is on homozygous FH, but as you see, we're weaving in heterozygous FH as well. And in both scenarios, we are terribly underdiagnosing the problem. Again, somewhere around 90% of patients with FH have not yet been identified. Now, a few years ago, that was fewer than 1% had been identified. But with the ICD-10 codes that came into being care of the FH Foundation, we've made some significant headway. Obviously, we have a long way to go. But I think the most important thing is to always have FH on the tips of our diagnostic tongues, if you will. If we think about it, then we might identify it. And when we make that diagnosis, we can make a difference. So early screening and diagnosis of FH and its variants is critical. As Kathleen mentioned, this is a problem that's genetic. So even in utero, patients with FH have extraordinarily high LDL levels. That's in utero. So they are essentially bathing in LDL cholesterol their entire existence. Right? Because of this, they have this extreme burden of LDL on their vasculature. And in the case of homozygous FH, if you look at the graph on the right, we could see that at a very, very young age, these children can get in trouble with an infarct, or even they can have sudden cardiac death. There are kids 5 years old who have died suddenly from an MI because of homozygous FH. This is something we need to note at birth, and we need to do something about it as soon as we can. With heterozygous FH, it takes a little longer because LDL levels are lower than in the patients with homozygous FH, and as a consequence, there's a longer time frame before these patients end up with infarcts. But still, at a very young age, they can have cardiovascular events. And I don't want to make it seem as though, although we are bifurcating homozygous and heterozygous FH, there is an area in between with the severe heterozygous FH patient who can surely look like a homozygous FH patient. So we have to be aware of that and not try too desperately to bifurcate these diseases and to be black and white about it unnecessarily. When necessary, we should do it, but unnecessarily, let's not do it. So if you look at the risks that we highlight here, young adults with FH have a 90-fold increased mortality from ASCVD. That's alarming and is certainly something that requires our extreme attention. Now, Kathleen mentioned that I was going to talk about xanthomas and xanthelasmas, and it is certainly critical for us when doing physical examinations to pay attention to and look for xanthomas, xanthelasmas, and corneal arcus. And what you can see here on the left is the cutaneous xanthomas, and these are typically on the extensor tendons. You see these lumps or bumps. We should look at the Achilles tendon always, in examining patients, especially in adults. We should always, when we feel pedal pulses, reach around, feel the Achilles tendon. If you do that, you'll realize that although it looks here on this image, when you look at the lower left of this gigantic Achilles xanthoma, you're often not going to see that. What you may feel is just a little thickening, a little lump and bump in the Achilles tendon, and that's your xanthoma. You won't see this extreme case necessarily. Look at the hands, as you can see, xanthelasmas are not pathognomonic as xanthomas are not pathognomonic for FH, but should be looked for. Corneal arcus, which is, you'll see in the center of the images, is a grayish hue in a ring around the iris. Corneal arcus typically starts superiorly and inferiorly before it becomes circumferential, and that's because the vasculature of the cornea is largely in those two directions, and it dumps cholesterol there. This is pathognomonic for FH in people under the age of 45. So if you see a corneal arcus, and by the way, what I do, my vision's not that great, so I use my iPhone, I take a picture of patients' eyes, and then I enlarge it so I can see whether or not they have a corneal arcus. But if you see that, under 45, pathognomonic. Now, Mona Lisa, we've shown this image quite a lot. If you look at her hands, you see a xanthoma on her hands, and she's got xanthelasma in the corner of her eyes. So we do think that the Mona Lisa had FH, probably HoFH with that xanthoma. So again, just to hammer this home, both HeFH and HoFH are terribly underdiagnosed. And if you're not diagnosing something, if it's not on the tip of your diagnostic tongue, and you don't make that diagnosis, you're not going to treat the patient according to the way the patient should be treated to mitigate risk of cardiovascular events. Remember, these people have events at a very, very young ages. So remember that about 1 in 250 individuals has HeFH, about 1 in 250,000 HoFH. That may seem like a very rare event, and it is very rare, but you may see these people. Again, 90% of these individuals are not yet diagnosed. And part of the problem is children aren't typically screened. Children should be screened. Cholesterol should be checked in kids by the time they're 10 or 11. In a child of somebody with FH, it should be done at the age of 2. This typically doesn't happen. All right. Also, the pediatricians often will hesitate to treat children So please be engaged. When children are 8, 9, 10 years old with heterozygous FH, they should be on statins typically. And younger than that, if they have HoFH, they should go for apheresis by around the age of 5 or so, and other therapeutics may be available. And let's not forget clinical trials. I do a ton of clinical trial work, and there are clinical trials available. A problem with our underdiagnosing this disorder is we're not typically cascade screening in the U.S. The Netherlands, where cascade screening is second nature, they've identified 70+% of their FH patients. We have identified fewer than 10%. We need to have diagnostic screening and early aggressive treatment, as I've said, and it would be nice to engage the pediatricians more, and certainly some pediatricians are doing this. It'd be nice to utilize our electronic health records to identify these patients. Now, the AHA diagnostic considerations for adult and pediatric patients with FH are, as you may see, a little unwieldy to some degree, but just keep a couple of things in mind. All right, you're going to look for LDL levels, and you're going to look for a family history. So LDL levels for heterozygous FH of greater than 160 in a youngster or 190 in an adult, along with a family history of either premature heart disease, which is a woman having a cardiovascular event under the age of 65, or a man, first-degree relative, under the age of 55, or high cholesterol, very high cholesterol. Now, interestingly, if you see a child of a known heterozygous FH or a homozygous FH patient, and the child has an LDL over 130, we actually consider that to be consistent with FH as well. So keep that 130 in mind as well. For homozygous FH, you see 400, 500, 560. The idea, once again, just keep in mind, very high LDL, use 400. I think this would make sense. Use a family history on both sides of the family of very high cholesterol and or premature cardiovascular disease. Remember, when we do genetic testing, by the way, that phenotype always trumps genotype. So I told you, a few moments ago that we're underdiagnosing this disorder, that we tend to bifurcate the disease, the heterozygous, homozygous. One thing that is in this conversation of bifurcation might be that you test somebody and you have one mutation, LDL's 400, 20-year-old person, xanthomas, family history on both sides, and you only see one mutation, and you go, it's a heterozygote. No, if the patient looks like a homozygote, it's a homozygote. He or she is a homozygote. All right. So in terms of genetic testing, should we genetic test? Yeah, absolutely. We should genetic test all these people. Is it going to be a black and white scenario where we find the genetic diagnosis and that's it? Only if you identify the one or two mutations can you make the claim or state that this is a heterozygote or homozygote, respectively. But if you don't identify the mutations, go with a phenotypic diagnosis, and that's very, very important. Some of the concerns people have about genetic testing is cost. Costs have come down tremendously. There are some commercial genetic companies that do a good job at a fairly low price point. Life insurance risk. You don't have a health insurance risk, but there is a potential life insurance risk. So typically in the older patients, I would suggest that they get their life insurance issues in order before they get tested. And the belief that results wouldn't change treatment is fictitious, because when we identify a mutation, that's a patient who's actually at higher risk than an FH patient without an identified mutation. We should know that identifying a mutation has some positive benefits, such as increasing adherence to lipid-lowering therapy, enabling us to cascade screen more readily by using a mutation. It's very easy, if you identify a mutation, to then go to the rest of the family and test for a mutation. Makes the much simpler process. So with regard to cascade screening, we think about it often in terms of heterozygous FH. Of course, we need to think about it in homozygous FH, and we may identify these clusters of individuals with HoFH. We improve our diagnosis. If we improve our diagnosis of heterozygous or homozygous FH, we improve our opportunity to intervene and to reduce risk. We improve lipid-lowering therapy adherence and outcomes. One of the big barriers to cascade screening is the family, believe it or not. The families often do not want to be involved in this conversation. And to that end, Kathleen will discuss some good tools that we have available through the FH Foundation and through other organizations that can help us encourage our patients and their family members to perform cascade screening appropriately. And now I will hand this over to Kathleen.
Okay, now we're going to take a look at some treatment strategies and guideline recommendations to optimize lipid management in patients with homozygous FH. Let's keep in mind that when we're looking at the treatment of homozygous versus heterozygous FH, the initial therapy for both is the same. So that we start off with statins, which would be the gold standard, high-dose statin with or without ezetimibe. This is guideline recommended first-line therapy for us. Now, if patients do have, you may find that statins and ezetimibe may prove to be less effective because their mechanism of action largely depends on the upregulation of a functional LDL receptor in the liver. And in homozygous familial hypercholesterolemia, you may find that LDL receptor activity is absent or greatly reduced. So we may say they have a negative receptor or null receptor, and that's when they have 0 to about 2% of activity, as opposed to a heterozygous, as opposed to having more receptor activity. When we say it's reduced, it would be 2 to about 25%. Now, most times in heterozygous familial hypercholesterolemia, we would see that our high-intensity statin, so higher dose atorvastatin or rosuvastatin, so atorva at 40 or atorva at 80 versus rosuvastatin at 20 or 40, you'll get a 50 to 60% LDL lowering. But with homozygous FH, you may get only a 10 to 25% LDL lowering. Again, look at the number of functional receptors that you have. And ezetimibe usually lowers the LDL cholesterol by about anywhere between 15 to 25%. And in homozygous familial hypercholesterolemia, we generally see that it's way less than 10%. And again, I can't emphasize any more strongly that patients with homozygous familial hypercholesterolemia are going to require multiple drug regimens to even approach their target LDL levels. And I think this is very important to stress or to tell patients right from the get-go. Look, we're going to start off with 1 or 2 medications, and we're going to very quickly escalate that, because they often are fixated on the fact that, oh, I'll only have 1 medication or 2 medications, and that is clearly not true. Now, as a mainstay, we certainly know that in addition to LDL lowering therapies, we want to foster healthy lifestyles, so a healthy dietary pattern, physical activity, daily physical activity, weight loss if the patient is overweight or obese, and the avoidance and or cessation of tobacco usage, very detrimental if they are a smoker. And again, patients will say, well, if my diet doesn't have so much to do with this, if this is an inherited kind of thing, but they really need to adhere to a healthy dietary pattern. So here's the algorithm that we have for treating homozygous FH, and this is for adults, and we're going to consider that in the guidelines greater than or 15 or greater than or equal to 15 years of age. Notice that the current version is the 2018 version from the AHA-ACC guidelines. And with our newer therapies that we have, we're certainly going to have updates that are needed that will reflect these new therapies. Now, if you're in the process of diagnosing homozygous FH, you're not quite sure, or if you have diagnosed it, I can't emphasize any more strongly than this needs to be done in consultation, and treatment needs to be done in consultation with a specialist. Oftentimes, folks are under the belief that, well, I can go to my cardiologist and my cardiologist can treat this, but your cardiologist may not be as well versed in how to deal with homozygous FH. And so you need to have a specialist. Obviously, we start with lifestyle improvements, but that is in conjunction with medication usage all at once. We don't wait 3 months, 6 months to see if they're going to be effective, because it's not. And then here we have our goals for primary prevention, less than 100 milligrams per deciliter, and secondary prevention, less than 70 milligrams per deciliter. But I want you to think about what Dr. Baum said. When these babies are born, okay, who are homozygotes, they are just bathed. They've been swimming in all of this lipid, okay? And so, first of all, I would push for the lower the better number that you can get. And it's going to be difficult to get to these either less than 100 or less than 70 milligrams per deciliter. In HoFH, LDL lipid lowering therapy is required from a very young age in order to prevent the onset and the progression of coronary disease. So it's not only a statin and ezetimibe, but it's also the use of a PCSK9 inhibitor or an MTP inhibitor like lomidopide, and LDL apheresis or lipoprotein apheresis. All of those are required, may be required, I should say. Now, what about the standards of lipid-lowering therapies and the unmet needs of our patients? So let's look at some of these traditional standards of care that we have, the benefits and the limitations. We've talked about the fact that statins are the mainstay of therapy. We have extensive evidence that statins reduce cardiovascular risk. We want to use a high-intensity statin, or the highest dose that the patient can tolerate. It's going to not only lower LDL, but other atherogenic lipoproteins. So this is a HMG-CoA reductase inhibitor. What are some of the side effects? Well, the higher the dose, the more side effects you can or you may anticipate seeing. So typically we may see myalgias or myopathy. You have to be concerned about drug interactions. And again, if the patient has HoFH, you're going to have relatively ineffective LDL receptor activity. So to the statin, we may add ezetimibe, and ezetimibe is a cholesterol absorption inhibitor, and it inhibits the absorption of dietary cholesterol by blocking the Niemann-Pick C1-like protein. And in, again, just to reemphasize, it may only reduce LDL by 10% or less. Side effects tend to be more rare, but you can have GI effects. Again, there may be little benefit in an HoFH patient. And then in using bile acid sequestrants, and I will tell you that bile acid sequestrants may lower the LDL cholesterol anywhere between 0 and about 10%. They can be, they're added to a statin. They can reduce the LDL cholesterol. They have other benefits. They may reduce glucose in diabetics, so in hyperglycemia. And it does, we know it does reduce cardiovascular risk. We do have an outcomes trial, but they're difficult to take, okay? They have GI symptoms. If the patient has baseline elevated triglycerides, we may see that they may further increase the triglycerides. There are multiple drug interactions so that you have to take it. You have to time when you take your bile acid sequestrant and when you may take other medications as well. Then, and what do they do? Their primary action is to bind the bile acids in the gut, okay? And they interrupt the enterohepatic recirculation of bile acids. So it has an important effect on hepatic lipoprotein metabolism. Now, alirocumab and evolocumab are our PCSK9 inhibitors, and they substantially lower LDL cholesterol. We do have, they do decrease cardiovascular risk, and we have 2 primary outcome trials, which I'll show you on the next slide. And in homozygous FH, they lower the LDL when added on to other therapies by about 21 to 24%. Now, there was a study that was done, a 12-week study in about 49 patients who had homozygous familial hypercholesterolemia. They were on stable background therapy, but they were not having LDL apheresis. And their LDL was lowered an additional 31%. And then there was another long-term study where they either used 420 milligrams of Repatha, or sorry about that, evolocumab, every month, or they used it on a biweekly, every other week basis of 140 milligrams. And there was an additional LDL lowering of about 24% in about 100 patients. And about 1/3 of those individuals were receiving LDL apheresis as well. So there is some benefit. And then with lipoprotein apheresis, LDL and ApoB containing lipoproteins are removed from the plasma. What are some of the negatives about lipoprotein apheresis? Well, it costs a lot of money. One treatment is about $2,300 to $2,400, and most patients require at least 2 treatments per month. You have to go, like I said, a couple times per month, if not even more. It's invasive, and you have to sit for anywhere between 1.5 to 3 hours. And I will tell you that's very conservative. I will tell you that most patients sit there for about 4 to 5 hours. And there's a negative quality of life. You have to build this into your schedule, as well as some people don't feel so well after the procedure. I want to go back for a second to the PCSK9 inhibitors for the limitations of the use, where we said one of them is subcutaneous injections. We had a big fear, or there was a fear that was out there that patients really would reject having to do injections, but that has not really proven to be the case. Folks have been so thankful for therapy that lowers their LDL cholesterol that they are more than willing to do those subcutaneous injections. But again, remember, you'll get about a 50% at least LDL lowering if you are heterozygous FH, have heterozygous FH, but it's only going to be about 20% or a little more if you are homozygous. Okay. And then this is the slide that just shows you an outcome study results from the 2 major cardiovascular outcome trials. Evolocumab was used in the Fourier trial and in alirocumab in the Odyssey trials. And you can see there was greater than 50% LDL lowering, and there was a decreased risk of cardiovascular disease. So 2 good medications. What are the limitations of these standard of care lipid-lowering medications? Well, first of all, if we look at the MTP inhibitors, lamidipide, first of all, they're expensive. They can cause liver toxicity, although in a 5-year study that was done, if you monitor the patients very carefully, they really didn't seem to have a lot of liver damage at all, not a lot of hepatotoxicity. Hepatic fat tended to stabilize, but they're difficult to take. You have to be on a very low-fat diet. You have to get your liver functions assessed very frequently. And there's a REMS, it requires REMS. So providers have to take a course with it. So a lot of patients really do not adhere to the therapy. And so that can be problematic. But if you have someone who's really very motivated, you can get good results with lamidipide. I think we've said it all with statins, PCSK9 inhibitors, the bile acid sequestrants, and ezetimibe. If you have less LDL receptor activity, you're going to find that your LDL lowering is not going to be as effective. And then with LDL apheresis, you will find that there are very dramatic lowering. There's dramatic lowering of the LDL cholesterol, but it's temporary. And so you get disconnected from LDL apheresis. And the minute you walk out the door, your LDL cholesterol levels begin to rise until they almost approximate what they were before in 2 weeks. So that can be difficult. And again, we talked about how it's invasive, it negatively impacts quality of life, and there's limited availability. And I think, don't hold me to this, but I think there's only about 60 centers or a little more in the country that provide LDL apheresis. Okay, so now, given that we have these limitations, thank goodness we now are able to optimize some of the outcomes for our patients with some of the newly approved therapeutic options. And so I'll turn it back over to Dr. Baum.
Great, thank you. Before I move forward, just 2 comments about one about PCSK9 inhibitors, the other about lipoprotein apheresis. So PCSK9 inhibitors in HoFH, just want to make this point. If there's a patient with null mutation, so 2 null mutations, that a homozygote, that person may have zero benefit from a PCSK9 inhibitor. So it's important to check the level very soon after initiating PCSK9 inhibitor, check LDL level soon after, so you know that you're actually doing something beneficial for the patient. That's just one thing I want to say. The other is I do apheresis, and it is challenging for patients. There's no doubt about it, but it's also very effective. So I don't want to give it totally a negative connotation. I wish there were more sites around the country that did apheresis, because I think it has a place for a few patients. So I just want to weigh in on those.
Yeah, thanks for mentioning that, because that is true. You have to really check your LDL levels in the with the PCSK9 inhibitors. And if you're going to administer a PCSK9 inhibitor to someone who is having LDL apheresis, you give it to them immediately after their LDL apheresis treatment as well, just as an aside.
Okay, so we have still a lot of ground to cover, so I'm going to kind of burn through some of these slides so we can get to a Q&A at the end. So we're going to just briefly discuss these newly approved LDL cholesterol lowering therapies, evinacumab, inclisiran, and bempedoic acid. And they're very different therapeutics, and they have, frankly, different purpose. Evinacumab, which is an LDL lowering agent, also does decrease triglycerides and is approved currently for outpatient intravenous use. It's given through an IV every 4 weeks, 15 milligrams per kilogram over 60 minutes. And it's indicated for both adults and pediatric patients 12 and over with HoFH. We'll go into evinacumab in greater detail in a moment. Inclisiran is a small interfering RNA that lowers LDL cholesterol. It's administered through subcutaneous injections, an initial injection, then 1 in 3 months, then every 6 months thereafter. And it's administered at the clinician's office. Has not yet had any outcomes data to support it, but it is a very substantial LDL lowering drug, reducing LDL about 50%. And then bempedoic acid, which on top of a statin or by itself or with ezetimibe, does lower LDL cholesterol. Some limitations include hyperuricemia and potentially tendon injury. It's indicated as an adjunct to diet and maximally tolerated statin therapy in adults with ASCVD and or HeFH. I should say that inclisiran is also indicated for ASCVD and or HeFH, patients with HeFH. Again, evinacumab for HoFH. So evinacumab. So it's an ANGPTL3 inhibitor. So just a quick overview here. So in the liver, we make VLDL, very low density lipoprotein particles. These very large particles, predominantly triglyceride, but with cholesterol as well, that then go around the body and under ordinary circumstances will drop their triglyceride off, making about 17 trips at skeletal muscle and adipose tissue before they become intermediate density lipoprotein, and then low density lipoprotein, and then are taken up by the LDL receptor. Now, the enzymes that act on VLDL, two of the key enzymes are lipoprotein lipase and endothelial lipase, so LPL and EL, as you see. And the LDL receptor is key here. It's key. It's very important because what happens, the LDL receptor is going to take up the LDL particles once those are made. But in HoFH, we have a non-functional LDL receptors, very poor LDL receptor functionality, or null or nothing. So these LDL particles build up. They just accumulate there. Now, endothelial lipase and lipoprotein lipase under ordinary circumstances are actually being suppressed or repressed by ANGPTL3. And if we administer an ANGPTL3 inhibitor, i.e. evinacumab, we de-repress the endothelial lipase and lipoprotein lipase. We let them act more forcefully. And the endothelial lipase in particular, when it's allowed to react that way on VLDL particles, makes conformational changes in the surface of the particle that ultimately will enable these particles and remnant particles to be taken up by remnant receptors, not the LDL receptor, because remember, this is HoFH, they're really not functioning very well. So all of a sudden you have all these upstream particles before LDL, that are taken up by the remnant receptors and destroyed by the liver. And what does that do to LDL? It drops it very, very significantly, nearly 50%, frankly, in HoFH, by eliminating the upstream molecules, the upstream particles that would ultimately become LDL. Okay, so it's a very different mechanism of action and very effective. And we see here the ELLIPSE clinical trial. This was a pivotal trial that led to approval of evinacumab, and this was in 65 patients with homozygous FH. 2/3 of them were on evinacumab, again, 15 milligrams per kilogram intravenous every 4 weeks, and LDL was reduced 49% in a placebo-corrected manner. So nearly 50% LDL reduction. And remember, this is an HoFH patient population. You heard what Kathleen just told us about how poorly our agents work at lowering LDL cholesterol. Here we're getting a 50% reduction, which was maintained over time. So the drug was approved and as add-on treatment for adults and pediatric patients 12 and over with homozygous FH. Here we have our safety data, very well balanced. There were no AEs associated with discontinuation of evinacumab or placebo, and no deaths in either group. We'll move on quickly to inclisiran, again, small interfering drug, and this is how these agents work. There's something called GalNAc that's attached to these the different strands of mRNA, the sense and the nonsense strand, and or the antisense strand, and the GalNAc helps the drug be taken up by the liver. It's taken up by the liver, and then moved into something called the RISC. The RISC is the RNA-induced silencing complex. The sense strand is jettisoned. You have the antisense strand, which then finds mRNA for PCSK9. And when it finds that mRNA, it kills it. And therefore, you don't make PCSK9 here. And this is how PCSK9 is inhibited. And the inhibition of PCSK9 in this fashion will reduce LDL 50 or so percent. And it's an excellent therapeutic that, again, was recently approved. Orion 10 was one of the many Orion trials that demonstrated clinical efficacy. Here you see that 52% reduction at day 510. The drug was approved December 2021 as an adjunct to diet and maximally tolerated statin for adults with ASCVD or heterozygous FH who require additional LDL cholesterol reduction. Again, this drug is administered initially, then at 3 months, then every 6 months thereafter in the clinic. Safety data also well balanced. Most common AEs, of course, were injection site reactions. And then finally, we have bempedoic acid, which is through ATP citrate lyase. You see here HMG coenzyme A reductase inhibitor. That's a statin. Bempedoic acid's ATP citrate lyase inhibitor. The cool thing about this drug is that it's really a prodrug that requires another enzyme that's present in the liver but not in skeletal muscle to activate this drug. So in skeletal muscle, this drug is not active. And that's one of the reasons it's believed that perhaps the drug is going to cause fewer myalgias and myopathies than the statins. The drug is not active in skeletal muscle. Here we have a number of these quote-unquote clear studies, Clear Harmony, Clear Wisdom, the Serenity, etc., that looked at bempedoic acid in various forms, alone, on top of statin, with ezetimibe, against ezetimibe, so lots of different permutations and variations. But you see this LDL reduction, which was statistically significant across all trials, that ranged anywhere between about 15 and nearly 40% reduction. From a safety standpoint, hyperuricemia, tendon rupture, these are things that have been identified. And otherwise, it's a very well balanced drug across placebo and drug as well. Long-term outcomes data in what's called the 043 study is not yet available, but soon, we hope. Okay, that was a rapid fire, so that I can hand it back to Kathleen. She'll go through this, and then we'll have the post-test questions and a quick Q&A.
Okay, so needless to say, patient education is very important in treating all patients with FH, and certainly in those with homozygous FH, and we have several resources. Now, first of all, when we prescribe the drug, it's important to be able to get it approved so that your patient can take it. And in order to streamline the reimbursement process for these new lipid-lowering medications, we provide our patients with education about how they should be tested and treatment information. We have information on, we do a lot of shared decision making with our patients, telling them about the benefits and the risks of the therapy, and ultimately making a decision together as to whether a drug is right for them. There are guides online about FH from an insurance perspective, and that's very helpful to patients. To improve cascade screening and communication to families, there are Dear Family letters that are available, and I'll show you some examples in a second. There are online conversational guides to help patients prepare for visits, either at the clinic or in particular with COVID now, with telemedicine becoming much more prevalent. We have availability to see where there are FH specialists, and there are lots of blogs and websites where we see personal stories of folks who have FH highlighted. Lots of videos and webinars and up-to-date news articles. And it's very important that we share this information with our patients. So they should be readily available in our clinics or downloadable for the patients so that they can have them right at their fingertips, because they may understand something when they are in the clinic or think they understand it. And as soon as they walk out the door, they're like, oh, what did he or she say? And so then it becomes clear as mud. So we have a lot of these helpful patient education tools. Now, here's barriers to optimal therapy would be, again, getting a prior authorization, and then if you are denied initially, how do you appeal that effectively? Well, a number of our organizations, from the American Society for Preventive Cardiology to the NLN to the Preventive Cardiovascular Nurses Association, have developed guidelines for prior authorization forms. And it's very important that certain information is included in order to get the medication approved, be it their LDL levels, what medications they've previously taken, are they adherent to a diet, all kinds of things. But you want to make sure that's included. And if you have a form letter or a form for that, it makes it so much easier. And then if you're denied, there are, we have templates for appeals, and they're very beneficial as well. And again, all available from these organizations. Now, one of the great organizations for folks with FH, be it heterozygous or homozygous, is the Family Heart Foundation, with their name just recently changed from the FH Foundation. And they have a variety of downloadable resources to help patients. I think it's very important for you to know the patient. And so are they computer savvy? Can they download things? Do they require something that is more pictorial versus something that has more writing with it? Some of our older patients really just can't navigate the computer. And then there are some people that are younger that simply can't as well, or don't have access to a computer. The FH Foundation provides, or Family Heart Foundation, not only provides information, but they're great because they really kind of connect individuals with FH. And so patients can communicate with one another and interact with one another, and it provides a lot of support for them. And again, I mentioned these tools providing access. They're provided by the NLA and the ASPC. They provide they're very practical tools to provide guidance on how to identify the right patient for the right therapy and to be able to eliminate the associated barriers of use. So they're really very excellent. So having said that, and that was in a very short period of time, but I would direct you to any of those organizations' websites so that you can have access to their materials. Let's go over a case study in an individual with homozygous FH. So this is Anna. She's a 32-year-old woman who's screened annually, who goes to her has a physical exam annually and gets a cholesterol screening. And interestingly enough, her history is that she's consistently had very high LDL cholesterol levels of above 400 milligrams per deciliter since she started screening at the age of 22. But she was told not to worry because her, even though her LDL was high, her HDL was also very high, and so that provided her protection. That is not a true fact. Okay, so but that's what people were told. She has not had any known cardiac event, and when she comes in, she presents with palpitations and discomfort over her left chest. So she doesn't have, as you do your physical exam, there are no stigmata of hyperlipidemia that you pick up. From a lifestyle perspective, she smokes. And then family history, there's a very strong family history of early onset cardiovascular disease, as well as cardiovascular related death. Her father died at the age of 38. And her brother sustained his MI at the age of 32. So very precocious coronary disease. And she did not previously provide this information regarding her family history. And sometimes you have to probe a little bit with patients. From a family planning perspective and children, she has a 2-year-old son and an 11-year-old son, and there are no plans at this point in time to have additional children. So she ends up having genetic testing, okay, and she had she had 2 mutations in the LDL gene, okay. And she also was found to have multivessel obstructive coronary disease when they went ahead and did angiography. Okay, so I also want to say something that Dr. Baum mentioned before, and that was if you do not have genetic testing, you can still be diagnosed from a phenotypic or a clinical perspective. And we have two sets of criteria that we readily use here in the States, the Simon-Broom criteria, which and the Dutch Lipid Clinic score. Let me just emphasize with the Dutch lipid score, you don't need genetic testing. If you have a score of 8 or above, okay, then that's positive. You have definite familial hypercholesterolemia. So it looks at what is your baseline LDL level, and then do you have any physical findings? Is there a family history of coronary disease, etc.? So you can be diagnosed with this from a phenotypic perspective as well as a genetic perspective, although we would certainly encourage genetic testing. So Anna, of course, was diagnosed with HoFH while she's being treated and getting her coronary disease to be managed as well. We're looking at cascade screening all of her first degree relatives to see if they have a risk of having FH. Let me just, okay. So now we're going to have a little bit of a discussion here. Based on this, on Anna's presentation, Dr. Baum, what treatment do you think should be prescribed?
Yeah, so first, let me just make two comments. We're a minute and a half over, so I appreciate if the audience just hangs out with us. We'll wrap this up fairly quickly. I do want to open this up to additional questions if there are any. And then I also want to say one thing. You had mentioned the family history, that it wasn't, her family history was not given earlier, at prior visits. I really want to emphasize that people are not going to give you the family history unless we really interrogate them. So whenever I see somebody in preventive cardiology or lipids, I always do a family tree. I think it's a great idea, especially to sort of focus in on HoFH and HeFH. That's a good thing to do. All right, so how will we treat her? Well, she needs a very, very aggressive treatment, obviously. And in fairness, what is she on right now?
Nothing.
Nothing. Okay. So the mainstay of therapy always is going to be statin. We're always going to start with statin. We'd add ezetimibe, and then we're going to move through a number of different drugs. This is a patient with HoFH. So, there are two issues with HeFH. People require multiple drugs. Why is that? It's not because the drugs aren't working. They are working very, very well, but you're starting with a very high LDL. You need multiple drugs to get the LDL down to whatever target you have. Here, you got a two-pronged problem. One, the LDL is even higher, so you have to knock it down. And then two, the drugs are not going to be that effective typically, because most of our drugs, with the exception of evinacumab, really most of the good drugs, with the exception of evinacumab, are working on upregulating LDL receptor as the method of lowering cholesterol, and LDL receptor is so dysfunctional or absent in these patients. So that's what I would do. Run through these drugs, do it fast. I like what you said. You're not going to wait 3 months or 6 months. You're just going to get this person to whatever target you want early on, quickly.
Okay. And then, of course, lifestyle changes. We're really going to focus in on smoking cessation. That's a big one.
Always.
So another question that I would have for you is, once treatment is initiated, when would you see the patient in follow-up? How soon?
Well, we remember that this is a young woman with homozygous FH and three, multivessel coronary disease, just had 3 stents, and requires aggressive treatment. So it's a matter of weeks that you see this person in follow-up. It would not be months down the road. And this is somebody I'd see very frequently until she was on a much more stable regimen. And then, frankly, even at that point, this is somebody who should be going to see you every few months, not somebody you say every 6 months or once a year. She's just too sick. She's at too great a risk.
Okay, great. Well, let's just go on from this point right now and look at her follow-up. Oops, did I go back? I went back. Sorry about that. Let's move forward. So here she is at 6 months, and we've certainly seen her long before 6 months. But with all of that treatment with statin and evinacumab, her LDL cholesterol is down to 138 milligrams per deciliter. But she's not at her target, certainly, of less than 70 milligrams per deciliter. So the question would be, would you put another add-on?
Yeah, so this is somebody whose cholesterol I want to be as low as possible. So I would pile drugs on as she tolerated, assuming she tolerates, until we got to as low as we can get. I don't think we should scoff at the 138 though. She started at 400, so with statin plus one other drug to get down here is sort of unheard of, and it's one of the remarkable aspects of evinacumab. Don't forget, we're dropping LDL about 50%. So so that's what I would do.
No, agree. Certainly she needs add-on. Yeah. So what are some of the clinical pearls for the treatment of HoFH? First of all, you have to find it, okay? So provide early identification. Look for it. If somebody has a family history of early onset heart disease or hyperlipidemia, look for it. Provide early treatment, treat aggressively, adjust your therapies if the LDL is not improved upon or not reaching goals, okay? And don't rest on your laurels. 138 milligrams is great, but it's certainly not where she needs to be. Incorporate the newly approved and emerging therapies in the treatment plan as appropriate. Do cascade screening of all first-degree relatives, and provide shared decision-making patient resources and tools. Dr. Baum?
Great. Okay, so in sum, again, identification, that's the key. You can't treat unless you identify. Always think FH. One thing to keep in mind, every practice in America has, typical practice in America has thousands of patients. FH, heterozygous FH, 1 in 250. So every practice has FH patients, and 90+% of these people are not yet diagnosed. We got to think about it. Homozygous FH, think about that as well. We have to understand the importance of aggressively managing LDL. LDL causes vascular disease. It leads to heart attack and stroke. Genetic testing is very important, but it doesn't, the absence of identification of mutation does not mean a patient doesn't have FH or HeFH or HoFH. It's a clinical diagnosis first. Genetic diagnosis is confirmatory and helpful for cascade screening. Cascade screening is key. We need to look at every family member, every first-degree relative of the proband or the index case has to be checked. FH, or familial hypercholesterolemia, is a family disease. It affects families. In the Netherlands, for every proband, every single case that was identified, 8 additional patients with FH were identified through good cascade screening. We could do the same here, and we should do the same. We should use standard of care therapies. We should understand their limitations, and we should reach for things that we know that work, such as evinacumab. We know that these drugs lower cholesterol very effectively. So now the post-test polling questions. Let's go through these. All right. Approximately what % of patients with FH are underdiagnosed? Ah, baby, this is beautiful. All right. It is 90%. Very nice. Okay, congratulations. Great job. Let's move on to the next. 28-year-old woman, recently diagnosed with homozygous FH, 2 children, older brother. Who gets screened? All first-degree relatives. Correct. All first-degree relatives. And we aggressively do it, and we use the tools that Kathleen mentioned. Next. Okay. Oh, 27-year-old. I thought you got away without 2 questions. 27-year-old patient, positive genetic test, confirmed diagnosis of homozygous FH, ezetimibe, Rasuva, 5 every other day. Which of the following therapies would you recommend next? I didn't even have to ask it. Correct. Evinacumab, nearly 50% reduction in LDL in patients with homozygous FH. Next question. This one's a little confusing, perhaps, but patient prescribed a novel lipid-lowering therapy, 27-year-old, homozygous FH. What tools do you use? Well, frankly, I'd use every tool you can get your hands on. Use the family template. Use the prior authorization form. And you're probably right to use a repeal request form since or appeal because you're going to get rejected. That's I'm sort of joking about that. But if you do, you use an appeal. Okay, and that's excellent. And next. Okay, you can move on to the next. So basically, I personally want to thank you guys, everybody, for being here, for sticking with Kathleen and me for such a long talk. Hopefully you enjoyed it. Please get your credit through the links that have been provided.